That was an incredibly informative panel, and I know I took a ton of notes. I'm sure you did too. Uh, I'm going to, my job is easy right now. And it's easy because I have such a phenomenal panel. I'm not going to go into their bios. You have their bios. I'm actually not even going to do a disclaimer because I'm going to talk so little that I won't need one. But just to cover myself, my name is Ron Taylor. I'm with the Federal Reserve Bank of New York. All remarks are my own and don't necessarily reflect the Federal Reserve Bank of New York or the Federal Reserve System. So for this panel, and David sort of teed it up for us with his introductory remarks, we're going to look at different ways that different players affect social determinants of health and improving some of the upstream social determinants. And with that, we have panelists who approach it differently. And what I'm going to do is really just turn over the reins to the panelists to talk about what they do within their particular organizations and how they do it. And then we'll do some follow-up questions coming off of that. So if I could ask each panelist to just go through maybe 3, 4, 5 minutes of who you are, what you do, and how you do it, and then we'll tie it all in together. So Tom Wright, President of Regional Plan Association, we're going to start with you.
Thanks so much, Ron. It's nice to be here. And I guess as president of RPA, I do get to speak for the organization, so I have a little bit of flexibility here. So Regional Plan Association, we're a private nonprofit regional planning organization that's been around for close to 100 years. We look at the 31 county region around New York City, kind of Hartford to Trenton, Long Island, the lower Hudson Valley. And once every generation, we create a long-range plan kind of that looks at what are the investments, the policies, the regulations that we're going to need to create a prosperous future. The investments in mass transit we're well known for, community development, housing, environmental stewardship, watershed preservation, and other issues. And that's kind of our bread and butter, and that's the type of work we've done for a long time, and we think we're pretty good at it. 2 years ago, we released RPA's 4th regional plan, just the 4th plan in our 100-year history. And for the first time, in addition to prosperity, sustainability, and equity, we talked about health as a key goal and value of the 4th regional plan. As we put it, everyone deserves the opportunity to live the healthiest life possible, regardless of who they are or where they live. And we started, and I know that this is something others will talk about, but kind of trying to incorporate public health into the transportation and mobility work we did, the community development, housing work we did, really actually gave us a powerful new lens to look at these issues that we'd been addressing for a long time and we had a lot of experience on, but to kind of put them up in a new light, look at them a new way. And I'll just pull one out. For over 20 years, ever since our 3rd regional plan, we had been the organization out there saying people ought to be charging to drive into Manhattan, congestion pricing. We were saying it in the 90s before there was London or Stockholm or Singapore or other cities doing it, and we'd been beating that drum for a long time and working with the Bloomberg administration and others around it. But over the last couple of years, as we started to tee this up again and go up to Albany and walk the halls, we started to talk about congestion pricing specifically through a health lens. We saw research that said that in Stockholm, when they started to charge people to drive into the city, and I know every city's different and air quality and mixtures and other things, but childhood asthma rates in Stockholm dropped by 50% after they started charging people to drive into the city because there was less congestion and air quality improved in those communities. You know, as people will talk about later, the county with the highest childhood asthma rates in the United States is the Bronx. But it's not just that there's a potential benefit, but how we implement that policy will have profound impacts on whether we get those kinds of benefits or, frankly, create worse conditions in other places. I'm also on the mayor's BQE task force, and I can't tell you the results of it, except to say that right now part of the reason there's so much congestion on the Brooklyn-Queens Expressway is because we basically pay people to go there, because we charge them in other routes to get into the city, and we make it free that. And so the application for ill or good of these policies will have enormous, very profound health impacts, and it's time we start to pay more attention. I think we're still just tiptoeing into this, and I have a lot to learn today, But for us at RPA, it's pretty fundamentally changing the way we think about many of these issues. What kinds of issues we're going to prioritize, how we are going to try and advocate for them, and as we put them into place, how we're going to try and implement them. So that's just kind of an introduction to what we're doing.
Great, thank you. Thank you, Tom. So Hector Batista is the Executive Vice Chancellor and Chief Operating Officer of CUNY, and we've had the pleasure of meeting once before. Hector was here as part of our Hispanic Heritage Month programming and served as a panelist with Rosa Gill, and so good to see you again, Hector, and please.
Well, thank you, Ron. It is really my pleasure to be here. It's always a little nerve-wracking when you're speaking in front of your mentor, one of your mentors. You know, Rosa Gill has been a mentor of mine for many years, and you know, I'm always honored to be in her presence. She's a really iconic person in New York City. Rosa, special shout out to you. I just want to mention a little bit about the work that Tom and his organization does before I get into CUNY. I happen to, quite a few jobs ago, be involved in the work that his organization that he's leading around the development of downtown Brooklyn. I was in charge of economic development, working for the Brooklyn Borough President when we were trying to really, we knew that Brooklyn had all the major trains going there, and we knew that if we were able to really make that connection and that voice, so we actually charged the regional plan to do a study for us. And I would tell you that our phones didn't stop ringing off the hooks where developers who saw the opportunity, a ready workforce, an infrastructure that was ready for that development. So I'm really very familiar with Tom. And recently we talked a little bit about congestion pricing, yeah. Previous other hat that I was wearing. But anyway, I am very lucky now to be the Chief Operations Officer of CUNY. And just to give you the sense of our organization, we roughly have about 275,000 students that we serve every single day. And in total, we actually service about 500,000. 275,000 are full-time and another 25,000 students who come in every single day and are getting certificates and all kinds of other sort of services from CUNY. And, we're very proud of the fact that CUNY, 3 out of 4 students at CUNY go to school for free, 4 out of 5 graduate debt free. And that's something we're extremely proud of because we know that, and recently we were ranked as at least 8 of our schools were ranked in the top in the country for upper mobility, Baruch being ranked number 4. So it really shows how a system like CUNY could have such a tremendous impact on not only a community, because in a lot of cases, CUNY is the anchor for a lot of communities. I use an example in Staten Island College. It is the largest employer in the borough of Brooklyn. So we know, the borough of Staten Island. So we know exactly what an impact that community, that college has in that system. So we really make sure that not only are we creating opportunities for local residents, but also really looking to make sure that from an economic development point of view, whether it's through our procurement process or other things along those lines, and I'm going to probably talk a little more about that a little later, that we're creating opportunities for those residents. So we have 25 campuses throughout the city, including a medical school and a law school. So the impact is extremely tremendous, the ability for our system to have a real impact. And we really service New Yorkers with tremendous news, with tremendous sort of issues around food insecurity, housing, and making sure that our students, under our new chancellor's mottos, we really are trying to make sure that the vision for CUNY is that every student at CUNY has not only an internship, but a paid internship. So we really are focused on really creating a full student that is ready really for the world of work. So I'm very proud and very lucky, a local kid from Brooklyn, to be able to lead this amazing organization. I never thought that I would have 45,000 people working for me every single day. But that task in itself is pretty incredible. But I think that I take that with a pride. As I mentioned, I don't forget where I came from, and that's why I gave a special out to my colleague Rosa Gill, because you know, those are the kind of things people like Rosa and others that who've created this opportunity for people like me to be able to sit here and really talk to you and tell it, you know, about the work that we do and the work that we're constantly doing across the system in CUNY. So I'm very happy to be here, happy to answer your questions.
Thank you. David, I thought this was about the Bronx. How did Brooklyn get in here? I was teasing about Brooklyn. So thank you. So
no, Brooklyn, don't get us started.
So you hear impact through planning and vision. You hear impact through education. Next, we're going to hear from Mitchell Katz, who is the President CEO of New York City State Hospitals.
Thanks, Ron. So Health and Hospitals, along with CUNY, is one of the great public institutions of New York City that people really should feel tremendous pride in, that we have 11 acute care hospitals, including Bellevue, which was established before the signing of the Declaration of Independence, along with 4 skilled nursing facilities, several of which were in Newsweek's top skilled nursing facilities in the U.S. We do all of the health care in the correctional institutions in the city and run a health plan. And what we know is that our patients very much are suffering from social ills as much as they're suffering from medical disease. They're suffering from poverty, homelessness, living in communities of violence with substandard housing. People are challenged by mental health issues, by the lack of transportation, challenges around transportation. What we see our role is partnering with community providers to address these issues. And we feel that addressing these issues is as important as making sure that people are on their correct medicine. We have a great Director of Population Health, Dr. Dave Chotsky, and he and his group have pioneered several strategies for how we're going to take care of our patients. So every single acute care hospital has a health legal partnership, because we know our patients often need legal help in order to stay in their apartments or to get benefits that they are entitled to. We've worked with Comunilife, with Rose's organization, and other housing groups in order to provide housing, and we want to do that more. We want to say, you know, we have land and we have patients who need housing. We need developers who are prepared to create housing on our property that our patients can live in. We have at every single Health and Hospitals acute care hospital, we have enrollers into SNAP, so that we can address food insecurity. And we also do delivered meals through several of our programs. We really want to be the system that does the very best job addressing the social problems that face our patients and that often prevent us from being able to treat their illnesses. Thank you.
Thank you. Thank you, Mitch. So next to Mitchell, we have Julia Ryan. Julia is a VP with LISC, not LISIC, which is what we have here, Local Initiative Support Corporation. So Julia, do you want to talk a little bit about your role and what you do?
Sure, thank you. I really appreciate the opportunity to be here. So LISC, as you may know, is a national community development financial institution, and our mission is really to create economic opportunity for all. So we see that very much as being aligned and, in fact, in many ways the same as supporting social determinants of health in our communities nationwide. We have 35 urban offices around the country and a rural program that's reaching about 2,000 counties across 44 states. So we feel a real personal responsibility with the resources that we are deploying in communities to impact the health and wellness of people and places. And I think anchors are, and always have been, a really critical partner to us in doing this work. We see, in many ways, our role as a CDFI as being an on-ramp, creating an on-ramp for the financial capital of anchors to help them achieve goals that you heard about so beautifully, I think, in the last session, that are really aligned with the world of community development. But also that we can join forces, link arms with the thought thought leadership and the human capital of anchors, and really the political attention that they do draw to our communities, which is such a powerful force for change in many of the communities where we're working that just have not enjoyed that attention for many, many years. And I think one of the things that we're particularly attentive to in this work is how do we take all that energy and attention and the extraordinary opportunity of investment by anchors and spur revitalization, but make sure it happens in such a way that we're not spurring gentrification or displacement. You know, truly, how do you make it equitable? And I think that, again, is a role where CDFIs in the community development industry really need to step up. Our research team just produced a report in the last few months that took a really close look at that in one neighborhood in South Minneapolis, the Phillips neighborhood, which for 20 years has seen extraordinary investment, in that case from Allina Health, major hospital, but also the Honeywell Corporation. So those anchors, you know, they were economic engines in that community. They brought that political attention. They also did a lot of direct programming and investment. And if you look, the Phillips neighborhood is still struggling today in many ways, but it has revitalized and improved across a number of metrics that we look at in the community development industry. But what occurred there was not the typical story where, you know, a certain piece of the population didn't benefit from that. In fact, maybe they're gone. What happened there actually is that the pie truly expanded. And our analysis really showed that part of the reason that occurred is that there were strong community development organizations, activists, developers, service providers that were working alongside those anchors all throughout. They had a shared vision. They weren't always in lockstep. They partnered when it made sense. They didn't when it didn't. But it was almost that the intensity of that voice alongside the anchors that ensured that there was an agenda there that really ended up with some inclusive, equitable outcomes for the community. And that's another piece of this, I think, for, you know, CDFIs and others in the community development industry, that we need to be attentive to that with our anchors to see that we're building the capacity of the community groups to do this work and really improve health for all.
That's great. And you talked about the shared vision, and I think that's so important, that when you look across collectively at the different groups that are looking to affect and impact this, that you have sort of that shared vision as maybe a starting point to bring the resources together. Last, certainly not least, we'll hear from Tyler Norris, who is the president of WellBeing Trust. New to the space or been around in this for a little bit? I just have to say before Tyler starts, doing some of the diligence on the panelists and kind of reading through and looking at their bios and some of the things they've done, I was so incredibly impressed by each and every one of them. But I think, Tyler, we've elevated you from rock star to saint in this space. So, look.
Well, this better add up then. WellBeing Trust is a relatively new philanthropy. We're 3 years old, dedicated to advancing the mental, social, and spiritual health of the country. And we're not faring so well. As many of you know, you've seen reports even in the last couple of weeks from the Centers for Disease Control and others that after 120-some years of increased life expectancy, almost 24 years in that time, life expectancy in the United States has dropped 3 years, the last 3 years, right? Driven primarily by what we are coming to know as the deaths of despair, what Angus Deaton and others, Nobel laureates, have described as the deaths of despair. Deaths from alcohol, opioids, and suicide. One of the first things we did when we founded this, Providence St. Joseph Health as the seed investor in this, is we partnered with the Robert Wood Johnson Foundation and Trust for America's Health to unpack what's underneath these deaths of despair, what's really going on. And obviously the opioid challenges of overprescribing is part of that and lack of access, but when you really get at what's underneath it, it is hopelessness and loneliness and isolation and despair that we self-medicate and are taking our lives this way. In other words, it's the issues in our communities that are in fact killing us, right? So as we started to ask the question, how are we going, and then, you know, with our board, we've set this goal of saving 100,000 lives from deaths of despair in the next decade. You know, I sleep pretty well, but I toss and turn over that one because we're going the wrong way, and I don't quite know how we're gonna get there. So our strategy right now is to, first of all, get the care right. and as many of you know who do this kind of work, integrated whole person care, spirit, mind, body, where physical health and behavioral health and the assessment and referral to non-medical needs as a standard of care, that's what integrated health needs to look like from primary care to the emergency department. We've got to get that right, and it is not the case in most care settings across the country. Integrated care. Secondly, we need to pay for that. So we need to make sure that we're addressing state and federal policy to assure that affordable access to that care is possible. And we know that people are dying every day for inadequate access not only to health care, but particularly to these determinants of health: food security, housing security, and the other factors that we know and are talking about here, community development factors that are part of this. We're trying to get the care right and trying to make sure that it gets paid for. But third, and we've partnered with many organizations, is to address the vital conditions for intergenerational well-being in the first place. Dr. Shomasaha is here with us. We've helped create something called the WellBeing in the Nation Network, which is a configuration of partners addressing the measures, the National Committee on Vital and Health Statistics, about what should we even be counting? How do we identify communities that are doing deep, place-based work that are really exemplars of what is working? We formed an alliance of leading NGOs, from the YMCA of the USA to Enterprise Community Partners to 4-H to the Yerba Buena Center for the Arts, to address how do these organizations working on these vital conditions, we formerly called the social determinants of health, how are they all geared to impact well-being? And how can they shape their organizational practices, come together in a co-benefit way around public policy objectives, and move investment capital to improve these underlying dynamics in the first place? Part of the reason I think I was asked to join this panel was my previous work. It was with Kaiser Permanente, which, as many of you know, is a large integrated healthcare delivery system in 8 states, headquartered in Oakland, California. It's an $80 billion health system serving 14 million Americans. We had a lot of money, $2.5 billion a year of community benefit investing, but it was not enough to even begin to touch the health status of the communities we were serving. A couple of $1 billion of community benefit dollars was nothing compared to the $22 billion a year of payroll. And yet we recognize it, we were not hiring from the neighborhoods we were serving. And the most important thing we do is creating living wage jobs in the neighborhoods we were serving as a primary determinant of health. Secondly, we had a $20 billion purchasing portfolio, right? 10 times our community benefit. We weren't buying from the communities that we were serving. And of course, you can't buy everything from the neighborhoods, right? Scanning, but we could be buying a lot of things. And so we started shifting our purchasing, and not only over $1 billion a year of purchasing from women and minority-owned firms, but localizing that purchasing. And thirdly, there was tens of billions of dollars parked in banks within a baseball throw of this neighborhood here, and it wasn't on Main Street, it was on Wall Street. And we knew we needed to start investing in the communities we were serving. One of the first investments, directed by the late Bernard Tyson, many of you know, who helped pioneer this work, a true loss for many of us and for this field, was investing $250 million, a first move out of that investment portfolio in affordable housing, $250 million to create affordable housing in the communities that we were serving as a real anchor. So healthcare organizations are vital for access. We need to make sure everybody has access. But as an anchor institution, we can partner in the ways that are describing here to really address the underlying vital conditions that create health in the first place. And that really ought to be a standard for what health sector is looked to and held accountable for.
See? Told you. That was awesome. So that was great, and thank you all for those overviews. I want to come back to you, Hector, and just talk about, so you touched on the procurement and the hiring within the CUNY system. Could you talk about how that's impacting and affecting the work?
Sure. I mean, sure. Our system, our budget is about $7 billion. When Chancellor Matos came into office in May, he basically put out a mandate. I mean, the governor has put out a mandate for MWE participation and making sure that we hit 30%. And basically what the Chancellor laid out is for me to lay out a mandate for the whole system in terms of participation. Because in a lot of cases, we're in communities where local businesses are really looking to CUNY and the systems that we have to really have opportunities. So we created, you know, what we call this mentoring program. And coming from where I came from, it was music to my ears, right? I ran Big Brothers Big Sisters around New York, and I chaired the national movement. So it was words that I understood. I didn't understand the academia side of this house, but I understood that word. And what we basically began to do at CUNY is really partner large businesses with small businesses to allow them to be able to really navigate our system. And those primes who have been able to get procurement through our system, how do you partner? And then really the ultimate goal is to make sure that minority-owned business and women-owned businesses are able to become primes, because that's where the real opportunity comes. So that's the first bucket. The second bucket is really trying to create, how do we connect those businesses to opportunities for our students? How do we make that connection? Now, no pro quo, we're not trying to do that, but what we're trying to do is see what are those businesses need, and what kind of labor force they need, and how do we connect those, make sure that our students are ready for those opportunities. And then the third bucket is how do we streamline the process so businesses don't have to wait for a long, long time to get the resources they need to get paid from us, right? That we make sure we're paying our bills on time. Now, I'm happy to report we're actually way ahead of schedule. I just gave the Chancellor, I'm not going to get ahead of him because he's actually presented to the board, and I don't want to get ahead of that either. But I'm happy to report that our numbers are really doing extremely well. And it starts with the top, and then the leadership at the top, and making sure that that gets across the system. So, you know, creating opportunities in communities that we are, in a lot of cases, a lot of our colleges are really in communities where, you know, there's a lot of the food insecurities, housing insecurities, economic development opportunities, and all those things. So I think that trying to make sure that those colleges are connected to the community in an important way. Now, I'm going to divert a little bit from the question, but you know how I thank Rosa Guillemette for mentioning. I'm going to actually thank somebody and also blame that person, okay? I'm going to blame former Deputy Mayor Nympha Segarra for getting me into the operations game when she's sitting right over there. When she, you know, because of her, I became Housing Commission. I was running HPD, and I want to thank her for that opportunity, because of that opportunity, I'm able to do the work that I'm able to do that, and I can't go without recognizing her. But the point of the matter is that CUNY has an ability to really have an impact in communities in an important way, and the Chancellor and his new team really get it, and that's the message that we're trying to send across the system.
Great, thank you. Mitchell, I wanted to ask you, so when I hear the phrase, no margin, no mission, and I think about sort of the prioritization of investments and things like that, could you just talk about that a little bit and sort of how you balance and figure out?
Sure. Well, I think that, I mean, it's absolutely true. No margin, no mission, but it can also lead to incorrect thinking. So I remember walking the walls when I first got to the hospital wards in Los Angeles, and I asked the doctors, okay, tell me, you know, what your issues are. And they said, well, we have all these patients who are here in the hospital who don't need to be in the hospital, and they're only here because there's no housing. I said, okay, well, why is there no housing for them? They said, well, we can't afford it. I'm like, funny, because a hospital day here is $1,500, and when I was, you know, being interviewed, they put me up at the Omni, and that was only $222. So it seems like at a minimum, we could put everybody at the Omni and save $900 a day. So, you know, yes, it takes money, but good business people understand that when you assess a budget, it's not, well, we don't have enough money for that. You have to do what does it cost and what is the benefit. I mean, how much illness would we prevent if we really addressed people's housing issues and their food issues. And I think to a large extent, the reason the American health budget keeps growing without improvements and now even worsening in health status is because we're providing a ton of tests, a ton of medicines, a ton of hospital days. We're not addressing people's health.
But I mean, that business case is pretty clear. How many would rather go to the Omni? Would rather go to the emergency room? So you hear it that way, and you kind of lay it out. That's pretty straightforward, and that's pretty simple to me. So why the difficulty in the shift in the thinking?
Well, again, there are
just generally
very smart people in this room who do money, but I'd say the quickest answer would be what I'd call the wrong pockets problem. Is that right? That the money is here. It's just that because of our siloed thinking, right? That we have certain streams that only pay for the MRI, but won't pay for me to house someone. And that ultimately, if we could move to a system, and I think single payer systems certainly get us a lot closer, because what you want is a system where you can pay for the things that produce health and at the same time capture the savings from making people healthier and need less hospitalization. Our current economic systems don't do that. So in many cases, if I save dollars by housing people, I'll just get paid less, which doesn't keep me from doing it. But it does make the business model harder to sustain.
Sure. Thank you. Tyler, you look like you wanted to comment as Mitch was talking.
I'll open it. I just was acknowledging. I agree completely.
Yeah.
Can I just add one thing
Sure.
to it? I mean, I think that I really appreciate what Mitch was saying. I think that when you're really trying to make change, I mean, you really people say, how do you make a change in such a huge system? I mean, you really begin to set a tone. And I think one of the interesting things at CUNY that the reason the Chancellor tapped me is he wanted somebody who was an outsider, come in with clean lenses. I don't come from academia. I've been lucky enough to run a lot of different systems. I don't want to make this about me, but the reason I'm saying that is that when I came into CUNY and I asked my staff why a second time, I love the Vice Chancellor, they know that it doesn't make any sense, right? And so a lot of it is bureaucracies that really get entrenched and doing things a certain way. And if you begin to break through that, you begin to really see results. And you begin to see results in a small little ways, but they begin to add up. And we've been there a short time, and we're starting to see that because we're leading with yes. And when you lead with yes, I say to myself, I lead with yes. It could be no, but we're going to lead with yes. And I think when you have that yes kind of a mindset, I think a lot of things sort of can happen in a large system. And that's why I appreciate what you say, because I think it's sort of all connected.
That's great. Tom, you launched your 4th regional plan a couple years ago.
Sure.
In terms of implementation, if you look at that plan, can you talk about how much of it and how difficult it is?
Sure. Well, I like to say each of the regional plans, we're kind of studied in graduate schools and other things, because each of the plans is a product of its time and helps to kind of define what, I think the state of the art of metropolitan planning is at the period it was done. In the follow-up, since we did our 4th plan just almost exactly 2 years ago, one of the things I've been really proud of is we've been partnering with other organizations around the country. 11 regional planning organizations, including some major city ones that look kind of like us, others that are more public sector oriented, others that are from very, very different metropolitan regions and different kinds of communities, and talking about how are they approaching these issues and incorporating specifically, again, with the focus on incorporating health into it. And that has both been, I think, informing our work and helping us inform them. Now, what it does is it goes back to some of these kinds of root causes. I will say, as a planner here in this room, I got to say, I'm representing an industry that has done a lot of harm also over the last 100 years. More and more, we're now looking very deeply at what we've done, and in particular segregation in communities and other things, and recognize that in the 1930s, the 1940s, and the 1950s, and to today, that we're dealing with legacies of housing segregation and others that were systematized in zoning codes and financing and other things that were part of essentially the tools of the trade for folks doing what I do, and even at the organization that I now run. So really trying to get at those root causes and try and undo them has become a big part, and understanding that those go directly to the health outcomes of specific communities. I've got to say, I love this kind of the wrong pocket idea, because we do see in our work billions of dollars invested in certain kinds of transportation systems that don't work, and we, if we could put it in another way, or we're under-investing in mass transit, which we know pays for itself with enormous kinds of environmental and public health and economic benefits, and yet we are, beggaring ourselves for our transit system and other things. And so we're trying to figure out how to create more of these flows and look to do it. And I do think, Tyler, what you said really, really does resonate with me, and I'll say I'm dangerous ground here, since a room of people who are more expert in this. But as you're talking about the despair and what's happening, I couldn't help but think, and again, I'm a planner, I look at communities, I look at the physical layout of communities, but I can't help but think that when people live in isolated communities, when they're cut off from other human beings, that these issues are going to come to play. And one of the big successes we had over my generation, over the last 20, 30 years, was a recognition, going back to Jane Jacobs, with public safety. And she said, eyes on the street make healthy communities. Holly White said, good uses crowd out the bad. And we started to understand and start to design communities to try and attract people into them, because we understood that those would be safer places. But we clearly haven't taken that yet to heart in terms of the isolation of what's happening in technology, and other things are frankly in many ways driving us further apart. And so there's a role, I think, for planners and designers, urban designers, architects, and others, engineers, to be thinking about the housing that we're designing and building, and where we're putting it, and the transportation systems, and where people are going to work, and how we're educating them, and everything else, to try to combat that. Because it's not just about, because if they live in communities, in healthier communities, where they're going to be interacting with other people, they're going to get help sooner, and I think that we'll get towards that 100,000 goal. That'd be my goal. But that's where I come at it as a planner,
1,000 over 10 years. Julia, in terms of technology, that was maybe a good segue. Could you talk about LISC and how technology kind of factors into some of the work that you do?
Sure. Well, and I think I'd actually, I guess in that vein, also like to make a play or a request that we all really think big. So before I, address the tech sector, which is big, I think what we've heard here, it's so interesting, is the extraordinary leadership and hard work that's required in each institution or system, right? Whether it be education or healthcare or what have you, to adopt an approach to total health, to really thinking about the power of the institution to improve community health. But if we keep each as individual institutions or systems doing our own thing, we're not going to solve these problems. And I think, Tom, you illustrated that as well. And we are in New York, but I will take you for a moment out to the Bay Area and San Francisco Bay Area, where, the tech sector, I think, is really recognizing the influence that they have, positive and negative, on livability in communities out there. And the housing crisis there is so extreme that, you have families with 2 wage earners, $15 an hour, who can only afford to live in 5% of neighborhoods in the region. Extraordinary. So the tech sector has been a target of LISC and saying, come on, you have a responsibility to step up with this. And we've actually had great reception. We've launched with many partners what we're calling the Partnership for the Bay's Future, or the Bay's Future Fund, BFF. If you want to be an insider, you can call it that. It's a $500 million fund directed towards affordable housing around the Bay Area. Kaiser Permanente is a major investor in that, a $40 million commitment to support that fund. And I think what it's doing is bringing the Facebook Chan Zuckerberg initiative, Genentech, San Francisco Foundation, so you've got public, private sector, all of these big dogs together around an agenda. not only to bring capital to solve some problems, but also to affect policy and systems. There's a piece of that fund that's actually supporting the municipalities with technical assistance and grant funding to change some of the barriers that are getting in the way of the affordability issues in their communities. So again, I think we need to be creative about who we're going to, but we got to go together, just given the scale of the problems we're taking on.
Wow. Yeah, no, absolutely. Shiv Khera was a motivational, or is a motivational speaker, and one of his quotes that always resonated with me was, leaders don't do different things, they do things differently. And I think what you're hearing right now is from 5 phenomenal leaders that are doing things to impact the space and doing it slightly differently, but recognizing the need to do it collectively. So this is just amazing. Tyler, I'm just going to give you an open mic.
Okay. Dangerous. Well, I actually want to build on, Julia, just the example that you just gave, and Tom, you speaking a little bit about legacies. The outcomes we have are the direct product of what we've been doing. This is...
Are we done?
that we spend twice as much money as any country, and we're in the 30s on health outcomes among the developed nations, is because of what is being so beautifully described here. So this should not be a surprise, particularly around race and equity, that so many people in this country, particularly those of color and early immigrants of this country, are disproportionately given opportunities to serve and engage meaningfully in the economy. And until we turn that around, we're not going to shift this life expectancy business. And that's a leadership question. The thing that I really appreciate, Julia, about what you just described sort of goes to something that we've all learned, those of us who've been in the healthy community field for a long time, is that most of the initiatives and programs and projects and grants we've done, 2, 3, 4, 5 years, have been tinkering. And in fact, a lot of the impact investing that's going on is tinkering, if I can just say that in this community. It is good work at the margin, but it lacks sufficient reach, intensity, and duration to have a population-level impact. But when you know that, it is unethical to continue behaving that way. And that's really the leadership challenge that's before us. So, what shall we do? I mean, the conversation, David, you and I have been having for years is that we are in the zip code improvement business in health. We have to be, right? Which is a community development agenda, right? This has been well said by so many others, so forgive me for saying this. One zip code is a greater predictor of your health status than your genetic code. Right? And we know that. And let's just not make that a cute quip. That is, in fact, the truth. So our community development strategies, how we do what, I'll put a quote on the table too. My mentor, one of them was James Rouse. He said, a healthy community is a garden to grow people in. So how do we create these gardens to grow people in with affordable access to safe housing, to transportation that makes work and school and facilities accessible to us, that addresses the first 1,000 days of life like the most precious stage of life that it is, that would never let a mom and her family and a child slip through after that first visit without making sure she has everything she needs to give birth. Because we know what happens when that first 1,000 days doesn't go well, and we know all so much about adverse child events and adverse community experience, the pair of ACEs, and we spend the rest of the person's life making up for those early traumas that we don't address well. So I think we have a real opportunity, particularly in this city that's rooted in investment, to ask the moral question about who are we as a nation, and a business question about how do we structure our investments to ensure that every person in this country has the opportunity to realize his or her potential. That's a community development question. That's a leadership question that I believe is upstream from the health crisis that we face. Otherwise, we're just going to spend more money for worse outcomes, and we know better. So
I would say if you want the answers to those questions, make sure you stay for the reception, and Tyler will give those to you. I don't know where we are in time, so I think on that note, we're going to go ahead and help me thank the panelists.